Hello, and welcome to another episode of LSVT Global's podcast, Think Big and Loud, where we share inspiring stories, expert insights, and engaging conversations, all designed to empower and uplift the lives of individuals with neurological conditions and those who love and support them. My name is Beth Peterson, and I'll be your host for the show. And today I'm very excited to be joined by my guest, Amy Chrest, and she is a speech language pathologist, advocate, and person living with young-onset Parkinson's. And she brings a rare and powerful perspective, having experienced Parkinson's both as a clinician and as someone navigating the condition herself. So today we'll explore what she's learned from living on both sides of this healthcare experience. We'll also talk about how her diagnosis has shaped her work and advocacy, and why sharing stories can help build stronger communities. So, Amy, thanks for joining us, and welcome to Think Big and Loud.
Beth, thank you so much for having me. I was so excited when we connected, and I'm just really glad to be here. Thank you.
Yeah, well, thank you for sharing your story with us. I'm glad to have your openness as we go through this.
Absolutely. And I'm always glad to be able to speak with another speech pathologist and kind of nerd out about all things
I
speech.
love it. Yes. Well, and I was wondering if to start, if you could take us back to your diagnosis. So, what did that moment look and feel like for you, especially being a speech language pathologist?
Yeah, sure. So I was diagnosed 9 years ago in 2017, but important for people that don't have Parkinson's disease to know that by the time you are diagnosed, you have already lost 60 to 80% of your dopamine. So for most of us, we have symptoms, both motor and non-motor, that have prodromal started before the actual diagnosis. So I could easily trace, I was 48 when I was diagnosed. I can easily trace my symptoms back to about age 39.
Okay.
Um, so, as a speech language pathologist, clearly, I work with people with Parkinson's disease. So all of the things are on your radar, because
Hmm.
we know the things that we work with in
Hmm.
terms of neurodegenerative process. Like many women, it takes typically, I don't have the data on this, but it does take longer often for women to reach the diagnosis because number one, women are not as likely to have a diagnosis of Parkinson's disease, much less young onset Parkinson's disease. When I went in, 39 is when my first non-motor symptom was anxiety. And, I've been a person who is wired for anxiety. So kind of my default, but this was extreme, extraordinary to the point of being dysfunctional anxiety and just like was pretty much all of a sudden. So I went to my doctor and, at that age, they said, oh, it's probably perimenopause. You're just
Yeah.
a busy working mom. And no, it wasn't.
Yeah.
So when I finally got the diagnosis after a lot of testing, MRI of the brain, um, muscle testing where they put the needles in you and shock the muscles, they're ruling out brain tumor, stroke,
Hmm.
ALS, MS. I was grateful, honestly,
Hmm.
because then I knew what I was dealing with.
Hmm.
Um, I had about three different neurologists, all within the same practice. Initially, they were like, "No, this can't be. You're too young. You run. You look too not whatever a person with Parkinson's looks
Hmm.
like." But my first diagnosis was actually Parkinsonism, which that was terrifying because Parkinsonism can have the Parkinson's plus, which is multiple system atrophy underneath that umbrella,
Hmm.
um, PSP, which is progressive supranuclear palsy.
Hmm.
And those are pretty rapidly degenerating progressive
Hmm.
diseases. So they referred me to the MDS, which is a movement disorder specialist
Hmm.
within the same practice. And he pretty quickly said, no, you've got garden variety young onset Parkinson's disease. We'll watch out for the MSA, multiple system atrophy, but pretty sure that this is what it is. So I was
Okay.
great. I was actually grateful when I got that
Mhm.
diagnosis.
Mhm. Well, and
Yeah.
yeah, like you're saying, just having a diagnosis so you know what to do next, I'm sure. I mean, it sounds like it took 9 years to reach the diagnosis. So then you finally had an answer and then you could start figuring out how to make the best of it, I think.
Yeah, yeah, and
Yeah.
I will say, when I had the anxiety, I didn't go to Parkinson's because that's a
Mhm.
non-motor.
Mhm.
When I started experiencing, probably about 2 years before my diagnosis, extreme muscle cramps, I was experiencing some, dysphagia with a little bit of saliva management
Mm,
difficulties. I could already hear my voice becoming a little dysphonic,
mm,
and the big one was I was having dystonia, and we'll get into the differences between YOPD and PD, but
mhm,
dystonia, for those of your audience who may not know, is a long-lasting muscle contraction in which the part of the body that is affected, the posture is unusual. So for me, I call it my
mm,
Spider-Man hand. My
mm,
dystonia did this in the morning, and then it pulled my arm behind my body. And I was like, "Well, what the what? I mean, that is not supposed to be happening." And
mm,
then I had the tremors started. So that was about a year and a half before I actually got diagnosed.
mhm.
Yeah.
Okay.
Mhm.
Well, and now that you've experienced care from both sides, I know
Yeah,
you mentioned that there was a staff meeting, like a moment where that dual identity really hit you. Can you share a little bit about that experience?
I can. So, I all of my colleagues now, and I work with a big department of, speech language pathologists. We've got about 10, but then we have our physical therapist, our occupational therapist, we have neuropsychologists, case managers, recreational therapists. It's a big department, a
Mhm.
very, very big department. And everyone, I've disclosed recently before I went to the Michael J. Fox Foundation first ever social media summit because I wanted to share that with them.
Mhm.
And, but we had a staff meeting. I was sitting in the very back, and we had some presenters who did not know me. And I was well aware when I raised my hand to ask a question that I needed to, be loud. I had to
Mhm.
be big and I had to be
Yeah.
loud.
Mhm.
But I was like what happens with Parkinson's, I was having a little difficulty in that large
Mm.
acoustic setting. Am I going to be shouting inappropriately, or will I be
Yeah.
able to modulate this? And I felt perhaps maybe this wasn't the case, but that my colleagues may have been like a little like, aware, like, oh, is
Oh.
she loud enough? Because the presenter then went,
Oh.
what? And I then, gauged it up, and I felt at that moment, this is what our patients with
Mm.
Parkinson's feel. All in
Mhm.
that moment, I'm formulating my question.
Mm.
I'm trying to not yell at anyone,
Yeah.
yet I'm trying to, clearly she didn't know me and she couldn't hear me. And
Yeah.
I was a little embarrassed, I have to say,
Mhm.
which I didn't
Yeah.
expect. Yeah.
Mhm.
Mhm.
Well, yeah, I'm sure that's helped you as a clinician, just very deeply understanding the feeling that those that you're treating are going through. Yeah.
Absolutely. And that's probably when I'm working with patients, what they share with me is if they have had therapy as an outpatient, and I'm inpatient rehab,
Mm.
right? So they're
Okay.
there for after an acute care. Um, and usually because of, well, something medically has happened that requires them to be there. But they share, like, I'm trying to be loud. Like, my family just doesn't get it.
Mm.
I am loud. I'm trying to be loud. And we know why. All that happens is
Mhm.
speech pathologists with the basal
Yeah.
ganglia play into the frontal lobe. But yeah, I felt for them. I felt for them
Mhm.
real because I know this stuff, and I was
Mhm.
still feeling a certain kind of way.
Yeah.
Yeah.
Well, and then I know you mentioned so you had the neuropsych evaluation. So what
Yes.
was it like being, on the patient side instead of the clinician?
Yeah, that was also, that's a real good segue into being both a clinician first. I've
Mhm.
done this for a little over 30 years,
Okay.
and now, being a patient. It was a very strange
Mm.
feeling, and
Mhm.
the neuropsychologist with whom I worked had a great discussion prior to my assessment, and we teased out what assessments I give so that they would not replicate anything as an inpatient rehab SLP,
Okay.
what they're going to give me. So, for
Mhm.
example, they might typically give the Boston naming test, which we
Mhm.
give. So that was off the table. We have some certain verbal fluency tests that we give that they also test. So we had to make sure that they were surprising me with a category,
Mm.
what that would be,
Mhm.
for example. And then when I actually got there, sitting on the other side of the table, I I know what my impairments are now.
Mm.
Before going in there, I knew what they were and I
Yeah.
knew what to call them because of what I do. So I can
Mm.
tell you the executive function is the first thing, probably about a year and a half ago, that really started plummeting quickly for me. So
Okay.
that's my multitasking, my complex
Mm.
attention, just taking me longer to problem solve and figure things out. I was
Mhm.
also having some memory issues, but with the testing, I learned that it's working memory that I'm having.
Mm.
So it's actually a retrieval of
Okay.
memory and not encoding. So I'm laying it down in my brain, but the
Mhm.
retrieval is weak.
Okay.
And then I had some, this is kind of frightening, some
Mm.
disorientation moments where I've been in very familiar places, and for a moment, when maybe I've come out of a room, or I'm like, I've got a few seconds of like, wait a minute, where am I?
Yeah. Okay.
Um, and then the testing itself was 5 hours, very intensive.
Whoa. Mhm.
Yeah, very intensive. And they design it that way in part to see what the fatigue does to the degradation of the cognitive skills and the motor skills. They also did some fine motor skills, which during that testing, it reared very evident that my non-Parkinson side is now also experiencing some moderate motor deficit. So we can
Okay.
say now that at 9 years, Parkinson's typically starts on one side. Now it's progressed to both sides.
Mhm.
Yeah. So, but with the one, I wanted to say, with the one assessment that I knew would be difficult for me when I started that assessment, and it's part of the executive function trail making, I started to cry before I even took it
Mm.
when I saw it. And I had to assure the clinician that was working with me, I said, it's okay. Kind of just ignore this. I said, but this is one of the things that I know has been
Um,
like, it's one of the things that I was like, this is not right. I've been doing this a
yeah.
long time and now I can't do it. So
Mhm.
it hits hard.
Yeah. Yeah, I'm sure that's frustrating
Frustrating
to
is a great word.
yeah, to be
Mhm.
so self-aware of it and know exactly what they're gonna test and how you think you'll do. Yeah.
Yeah. And I have to say, when looking at my profile, it matches exactly what you would see for mild cognitive impairment with a person with Parkinson's. So the
Mm.
first thing we typically see is executive function decline. That was
Mm.
my multitasking.
Okay.
Working memory. That is my ability to know when I'm talking. I might need a little extra time. It's not that I've forgotten the word, it's more of a retrieval versus when we get older, when you have typical Parkinson's disease, age 65 and older, that is more of a pure, like, word finding difficulty that maybe they've lost the words a bit.
Mm. Mhm.
Um, and the good news is, and this is typical, my language skills are preserved.
Mm. Mhm.
And, you know, um, number one, we're speech language pathologists,
Mm.
right?
Mhm.
So this has always been my strength in terms of
Yeah.
vocabulary word, but I haven't lost that.
Mhm.
Um, thank God,
Yeah.
as a speech language pathologist. But I
Yeah.
knew that going in. I could tell.
Yeah.
But it was more of the executive function, working memory, and visual spatial skills as well as gotten really
Okay.
poor. Yeah.
Yeah. Well, and so I know you've touched on some of the cognition changes you noticed. What about, what was it like to notice changes in voice and swallowing, or even if you wanted to touch more on cognition, I
Yeah.
guess knowing what you know clinically, and you've kind of touched on that a little bit too, but just
Mhm.
what has that been like for you?
Yeah, it's very interesting. Before I was diagnosed and my spidey senses were going off along with my spidey sense dystonia that I was having. One of the things I was really having some difficulty with swallowing saliva. It's really strange because that has kind of resolved in a way. I'm not
Oh,
having that, but I was having like an abundant amount of saliva initially
okay.
where I was having to swallow a lot and I could feel my muscles, over time in my face kind of get a little tighter, like, and not in
Mhm.
the way that we want them to, just kind of
Yeah.
reduced range of motion. Now that I'm further into it, when I am experiencing dysphagia, which I am, I see it in my brain.
Hmm.
So when I'm swallowing, I'm doing it automatically. I'm not trying. I'm seeing as if I'm looking at my own modified
Hmm.
barium swallow study or my own fees. And I can say, I know that I've got pharyngeal residue, probably at the vallecula, and I feel it's at the level of the piriform sinus. I need to swallow, do my effortful
Yeah.
swallows. And I'm kind of, I know what foods, the more viscous, sticky foods like a bread or
Hmm.
peanut butter, that's going to be more difficult.
Hmm.
And with my thin liquids, I have started to increase at least penetration in some real hard aspiration moments. Um, and so, yeah, it's really bizarre. It's like I'm
Hmm.
seeing my own modified.
Hmm.
Um,
Hmm.
and that's I talked a little bit prior to us talking was that's when I got checked by my neurologist because when you
Oh.
go in, yeah, I go in like every 6 months, sometimes
Hmm.
every 3 months if we're at a point where like, gosh, that seems to have declined a bit quicker than we would
Okay.
expect. And so I tell them this, they always say, how's the swallowing? And I tell them where I am. And then I say, but I think I'm good. I don't think I need to, this is bad. I don't think I need to get a swallow test, which is do what I say, not as I do, people, because we should, and I should, and I will. But this is when and I go through, I know what's happening. And she's smiled, the PA smiled and said, Amy, you
Mm.
know, um, this is where you can't be your own speech
Yeah.
pathologist. We really need to discuss going in and
Mm.
getting an assessment. She
Mm.
said, you need to step out of the speech role, be the patient, and have an assessment like you would recommend anybody else to do.
Mm.
So,
Yeah.
and I
Yeah.
said, no, taken will do. Yeah.
Okay. So you were a good patient.
Yeah. Well, and yes, I haven't done it yet, but I will be a good patient.
Okay. Okay. I
Yeah.
like it. I'll hold you to it
Yeah.
now. The whole world hears you say
Whole
it.
world's
So
gonna hear it. Yep. I've got my
that's
next
great.
appointment into July, so I'll
Okay.
discuss it all that.
Okay. Well, good. Well,
And
and
then
can
the
you?
other thing
Oh,
was the dysphonia you talked about
yeah.
with my voice.
Yeah.
Definitely, by the end of my day when I'm talking, my glottal fry that
Mm.
I have right now, but it's appreciably worse. So, and my volume gets a little bit lower. So I'm just tuned into it
Mhm.
like
Yeah.
any speech pathologist would be.
Yeah.
And it's frustrating. It is.
Yeah.
Yeah.
Yeah. I mean, I think in some instances it's really helpful to know what's going on, but in others I can see you probably think about it all the time and you know what everything is, and probably are analyzing everything you're doing. You don't get that kind of respite from like your healthcare provider is trying to tell you, but it's hard to just step back, and
Yeah.
if you
And
know
tha
it,
and
you
that's
know what's
y
happening. Yeah.
exactly. Thanks for saying that, Beth, because that's another piece when I first got diagnosed. I told him, "I know what I know. I know what I
Yeah.
know. I've been doing this. I can't unknow it."
Yeah,
So
yeah.
that's where I had to let everything sink in and not future trip and
Mm,
say, I know what this looks like from what I've seen in other patients.
yeah.
But one of the things that we will share, and it's with other neurodiversities or neurodegenerative diseases, if you've seen one person with Parkinson's,
Mhm.
you've seen one person with Parkinson's.
Yes. Mm,
So just because other people, have ABC and severity doesn't mean that that's where I'm going to go in the same time frame they did. So I need to rein it
okay.
in, you know.
Mm.
Yeah,
Well, I can tell you're trying to do the best you can, and it sounds like you're handling things really well.
thank you.
And I was wondering if you could tell the audience more about the differences between symptoms of young onset Parkinson's and Parkinson's, because I
Mm,
know some of those, that can be challenging to know those differences. If you could touch on that a little bit.
yeah, I absolutely will. And I'm just gonna go back again and say if you've seen one person with
Mm,
Parkinson's, you've seen one person with Parkinson's. And if you ever go on any research list and you see like YOPD is compared to PD, I'm going to start with our speech stuff and swallowing stuff.
mhm,
Often it will say, when you comparatively, young onset Parkinson's, and let me just back up. Young onset Parkinson's disease, by definition, is diagnosed before the age of 50.
mm,
Typical idiopathic garden variety Parkinson's disease is diagnosed 65 and older. So often you will see in YOPD swallowing issues or dysphagia starts to happen much later.
mm,
Not true for everyone. It hasn't
okay.
been the case for me.
Mhm,
Um, the other and with YOPD, now that this point would be true, generally speaking, you would not expect to see a person with YOPD develop an aspiration pneumonia
mm,
that is to a severe degree or even, in their
mhm,
first several years. PD, typically 65 plus Parkinson's disease, you have to be very, like, we need to be on it with the
mm,
dysphagia
mhm,
because from a pathophysiology standpoint, when you're older, you have vascular involvement,
mm,
just from cortical vascular involvement that we're probably not going to have with YOPD because of aging. We're
mhm,
going to have presbyphagia,
mhm,
presbydysphagia, the older
mhm,
swallowing muscles, and presbyphonia. So we've got age-related natural changes on top of the Parkinson's disease.
mhm.
With the YOPD, we're not going to have those aging
Yeah.
brain functions. The other thing is with I talked about with the cognitive piece, YOPD, we are less likely to develop a Parkinson's disease dementia
Mm,
early on. It would be typically later on in the span of your disease, and by later on, I mean some research shows 15 to 20 years. I'm 9 years in and I've got the mild diagnosis, but I have some moderate things within it. But then I still have some superior, high superior things with
mm,
vocabulary, language stuff.
mhm.
Um, and that's on testing. That's, not me saying it like I'm not superior, just but empirically, like what am I
Yeah.
losing and what do I still have kind of thing.
Yeah.
But with folks with PD, 65 and older, dementia is a real concern and it's going to happen sooner
Mm,
again. If it's going to happen,
yeah.
50, I've seen 50 to 80% of people can expect to cross over into some severity of dementia.
Okay.
Um, but again, because they're older.
Mhm.
Yeah.
Mhm.
And then when you look at young onset Parkinson's disease, I've talked about dystonia. We are more likely to have dystonia. Older folks,
Mm,
PD 65, not so much. So
mhm.
we're going to have the abnormal posturing. And then we also respond differently to the carbidopa levodopa or Cinnamon, which is the gold
Mm,
standard
mhm.
medication. We may respond better, but then also we tend to get dyskinesias. Whereas typically maybe our PD population might not. And dyskinesias are like you see the dancing rhythmic movements of
Mhm.
folks like our friend Michael J. Fox, who,
Mhm.
he was diagnosed at 29. So those movements aren't Parkinson's. That's a
Yeah.
side effect of the medication. And because we live with this longer,
Mhm.
we're going to take more medication longer for a
Mhm.
longer period of time and more likely to develop those dyskinesias. So
Mhm.
that's a whole nother thing of balancing what medicine do you take,
Yeah.
how much, the payoff. Do you want a tremor and be stiff? My big thing is dystonia. I have tremors, but it's painful. I get locked up, and
Mm.
muscle rigidity, of the four things, muscle rigidity and tremor. Do I want to risk getting stuck in the grocery store? Like my muscles just
Mm.
freeze like I have? Or do I take more and dance a little bit?
Mm.
It's
Mhm.
everybody's
Mm.
different.
Mhm. Well, and as you're talking about symptoms, can you also talk a little bit more about the non-motor symptoms? I know those can often be overlooked or misdiagnosed, like in your case, just not thinking that was anything related to Parkinson's. So can you tell the
Yeah.
audience a little bit about those and how they may impact quality of life?
Yeah, thank you for asking that. That's a really important one. So the non-motor symptoms of Parkinson's, insomnia,
Mm.
uh, our autonomic nervous system can be impacted. So we may experience orthostatic hypotension. So if you're going from sit to stand, for example, my blood pressure drops. So I have to be aware of that because that is a fall risk. Um, Constipation is a big one
Mhm.
because and that's when I talk to my friends in my YOPD community, that's one that is so bothersome because
Mhm.
in the GI, everything, think about Parkinson's is slowing of everything.
Mhm.
Bradykinesia means slowing down. And then the muscle rigidity, not moving as well. Well, that happens inside too. So the dysmotility of the esophagus and the peristalsis, the GI system not working great. So everything gets stuck. So
Mhm.
um, constipation, insomnia. I talked about the orthostatic hypotension. The three kind of mood things: depression, anxiety, and apathy.
Mhm.
Huge.
Mhm.
Maybe the ones that I hear frequently from within my community are harder to deal with than the physical.
Hmm.
Um, for me, depression certainly has been a
Mm.
very um, difficult one for me to manage, but I do manage with counseling, with medication,
Mhm.
exercise. And then I want to be clear on differentiating apathy from depression because a lot of people think it's the same.
Mhm.
Apathy is very common in Parkinson's disease. That looks like I'm not feeling blue. That means I don't want to do anything.
Mm.
I'm just going to sit in this chair. And I know I've got to get up and exercise, but I don't feel like it.
Mhm.
Um, so think about your patients. If you have a patient with Parkinson's, that even if they're not depressed, they have apathy, there might be some stuff going on at home to even get that patient to go there. Like, come on, honey, we got to go. They might
Yeah.
not be real interested, or it's just like too much to do these exercises. And it's
Mhm.
not because they don't want to. It's because the dopamine,
Mhm.
which is the neurotransmitter for movement and mood and sleep regulation, and serotonin, norepinephrine, all of those feel good neurotransmitters,
Yeah.
they're very depressed, meaning diminished. They're very
Mhm.
diminished and we're not functioning great. So just that's something you've probably seen the iceberg model with traumatic brain injury, or, where the things that you can see of the iceberg
Mm. Oh, yeah.
are up here, right? So with
Mhm.
Parkinson's, you can see my rigidity when it happens. I'm on now. I've made sure I took my medicines right before we started. Which is another thing with YOPD and working. I've got to gauge when do I take my medicines, and they
Yeah.
make me a little
Mm.
nauseous. And there's a food you can't take with a protein.
Yeah.
But above the iceberg, you will see the four main things: muscle rigidity, bradykinesia slowness, tremors, and postural instability, balance. Underneath, you're not going to see the insomnia and the apathy.
Mm-hmm.
And those are just things to be aware of because they impact quality of life.
Mm-hmm.
Yeah.
Mm-hmm. Yeah, it is. It's good to be aware of, and you're exactly right because, we talk to clinicians too. You might have someone in your treatment room who wants to get their voice better and wants to work on it, and you think you're being fun and engaging, and they're sitting there with a blank face. And so,
Mhm.
as a clinician, it can be hard. Like, oh, they're not responding to me. What am I doing wrong? Maybe I shouldn't do it. But it's good to be aware of that and know, no, keep your energy up. You try to pull it out of them, but there are other things going on that you don't necessarily see. So I think that's very good wisdom for clinicians to be aware of, as they're working with those with Parkinson's. So thanks for
And then,
sharing that.
yeah, you mentioned the blank face. So that also goes with the masking, right? And
Mm-hmm.
that can be, I know personally for me, we were talking about like interacting, maybe at a job, how's that is one thing for me because I am a joyful person to my core. I
Mm-hmm.
love to have fun. But with the masking that has occurred, I find that I have to, it's not fake, but I have to remember, like, maybe Amy, you look a little angry. I've had people come up to me and say, What's wrong? Are you okay? And I'm like,
Mm-hmm.
no, I'm good. So sometimes I smile on purpose. It's not a fake
Yeah.
thing, but it's because I don't want people to think that I'm angry or disinterested.
Mm-hmm.
So that's also the thing as a clinician, know that masking coupled with the apathy, coupled with some cognitive changes, it's a mix for sometimes a challenge in therapy.
Mm-hmm. Mm-hmm.
Yeah.
And I know you shared before that you have shared your diagnosis with other professionals. Now, what
Mhm.
about when you're working with people with Parkinson's? How do you decide whether to share your diagnosis with them? And how has that decision, I guess, affected your relationships or shaped those relationships?
I think that is like such an important question for me as a clinician and for any of you as clinicians that might have something similar.
Mm.
For me personally, I do not share.
Okay.
I do not share because I do not want to change the dynamic of I'm a speech language pathologist and I'm focused on you.
Mm.
I'm
Mm-hmm.
concerned that if I share that, now while it could be very rapport
Mm-hmm.
establishing, I don't want to detract. This is their time. This is
Mm.
their time. And I don't want them for a moment to then shift their thinking into, oh, looking at me or trying, I want them to focus on what they're doing.
Mm-hmm.
Um, and I want it to be all about them. Now,
Yeah.
I have had I had a patient that came back to visit me uh, and did not have Parkinson's. A young man that was, had a stroke, and but he came back and visited me probably, I don't know, 6 months after he was discharged, and it was before I was going to go to the Michael J. Fox Summit. And he's like, "Well,
Mm-hmm.
what's going?" He came back to thank me. First of all, I have to say, he
Mm-hmm.
came back to thank me. Young guy, dad, and he said, "I just want to let you know I did my first at work presentation and led a group." And he said, "If it weren't for you, I wouldn't have been able to do
Yeah.
that,"
Yeah.
which is why we do this, right, Beth?
Exactly. Yes.
It's why we do it. So he said, "What have you got going?" I said, "Well, I think I want to share something with you because
Mm.
we're not working together anymore." And I told him, and he immediately got tears and
Oh.
said, you know, it just reminds me to remember that everybody's got
Mm.
something kind of thing. And he's like, "Thank you
Mhm.
so much for telling me." But that's a very few and far between. And because I wasn't working with him anymore, kind of
Yeah.
thing.
Mhm.
Yeah.
Well, and I think that's a good lesson. I was even thinking this a little bit when you were talking about the iceberg. Like, everyone has something that's going on and you don't know. So I think
Mhm.
that's really a nice story to illustrate that, and that he has come to realize it after you shared it, but at the time, didn't know and doesn't think about that. And I think that's very professional of you to keep it that way. I can completely, I actually didn't know how you were going to answer that question. So it was really interesting to hear the direction that you go and your reasons for it. So,
Yeah,
yeah.
and then so I think about his response was, and we had obviously established a really good rapport,
Hmm.
and his response was to get a little tearful. Now, if
Yeah.
I shift that into telling him that when he needed me to work
Right.
on all
Yeah.
the things we're working on, that would have taken away from him. And
Hmm.
that's a no-brainer for me.
Hmm.
You know,
Yeah.
I want to focus 100% on them.
Yeah.
Now,
Okay.
I have had um, some some of my colleagues say, Amy, I've got a person who's diagnosed with young-onset Parkinson's disease. I'm not seeing them for whatever reason. Maybe they didn't initially get a speech consult because they weren't here for Parkinson's. They were here for something different. Will
Mm-hmm.
you come see them and just talk to them?
Hmm.
And my response has been, let's get, our admin in and make sure that that's okay first
Mm-hmm.
from, just kind of being conscientious of my employer. And
Hmm.
it's approved, and I go and talk to them, and it's been so amazing. So
Hmm.
amazing. And that's a whole different thing, right? Because I'm
Yeah.
talking
Hmm.
like doing a bit of advocacy under the permission of the
Yeah.
rules of which I work. And that's been delightful. I
Yeah.
love that. Yeah.
Okay. Yeah. No, that all makes sense. Well, and like they're all lucky to have you, and I can tell you take your job seriously and the care that you provide to your patients, and then also other relationships. So,
Thank
yeah,
you.
thanks for sharing how you do that.
Yeah.
And then I did want to talk because we love research, as you know, and I know
Yeah.
you've participated in clinical trials and research. And so
Uh-huh.
I'd love to hear a little bit about that experience. And I know you also mentioned the issue of women being underrepresented in Parkinson's research. So I'd like to hear about that as well.
Everything you said ties into why initially when I was first diagnosed, after I took a beat to like tell my husband and cry to him and tell him that I'm sorry, I think you married a lemon, and I turned out to be not what you married, and I'm not, and he, after I got that out of my head, and he hugged me and he said, Amy, you are the person I married, we'll in sickness and in health kind of thing. But then I said, okay, well, what can I do with this? How about a clinical trial? So I talked to my MDS, and because I do live in an area in North Carolina that has centers of excellence within Duke University, UNC Chapel Hill, there's NC State, just a very research laden
Mm-hmm.
community. I was able to participate right off the bat in a phase 2 clinical trial.
Okay.
So phase two is when they have a select group of people who, in this instance, I was trialing it was a pill form, and it's been a while, so I can't tell you exactly what the actual trial was for. Um, but it was very, it was to see how I would respond to this more uh, homeo natural form of medication, almost like a supplement thing. And they were looking
Okay.
to see if I would have any side effects, that kind of
Mm-hmm.
thing. So that felt really good to say, okay, I can't control my Parkinson's with
Mm-hmm.
the exception of exercise, which is what
Mm-hmm.
I opted to do for the first 5 years in lieu of medicine. A lot of people said, what,
Okay.
when did you start medicine? For me, I did not want to take the medicine because of the dyskinesias.
Yeah.
So I exercise was my jam. I ran. So that's
Mm-hmm.
neuroprotective. That's one thing I
Mm-hmm.
really want to make sure everybody knows that word, neuroprotective and
Mm-hmm.
exercise. That is the only evidence-based research tool or medicine, exercise is medicine, that will help prevent the
Mm-hmm.
neurodegeneration of my brain. Um, so the clinical study, then after I decided 7 months after diagnosis that I was going to go public, meaning tell my colleagues, tell my employees, employers, colleagues. Then I thought, well, I want to get involved with the big org. So I reached out to the Parkinson's Foundation,
Mm.
the Michael J. Fox Foundation. I started my social media advocacy because I was not on social media. I wasn't on Instagram until like a couple years ago. And I only got on because, well, the first reason I got on Facebook because I joined a medical SLP group, and to access part of what I was paying for was through Facebook. And I'm like, well, if I'm going to pay
Oh,
for this, I'm going to get on Facebook.
yeah.
But I wasn't until, I never on social media. But when I went on Instagram, I thought I'm going to type in YOPD women. And boom, I was seeing people like me, which I
Oh,
spent 7 years not
mm,
telling anyone.
yeah.
So isolated. I
Yeah.
didn't know anyone around me.
Mm,
Then I started getting into, well, what about the research? And there is no research,
mm,
limited research. I'll say
yeah.
limited research. Women have hormonal changes
Yeah.
that make Parkinson's symptoms worse, and the Parkinson's makes the hormonal symptoms worse.
Mm-hmm.
I was like, every month I'm debilitated. No
Mm,
research on this. So
mm,
that was another reason why I wanted to participate
mm-hmm.
in research. And then I was invited to be a research advocate with the Parkinson's Foundation,
Okay.
which has offered me so many cool
Mm,
opportunities. I've been on steering committees for companies like pharmas that are partnering with the foundation that are doing research, looking at drug protocols, looking at, and you don't always, to be research, folks, if you want to participate, you don't always have to do, excuse me, like I did in phase 2 and take a pill.
yeah.
It's not always like that.
Mm,
I've done studies in which I'm ranking patient facing materials as a
mm,
patient.
mm-hmm.
And they want you to look and say, can you understand what this means? What recommendations would you give for
Yeah.
visuals? That kind of thing.
Mm-hmm.
Each of the big orgs have some things that you can participate in. Parkinson's Foundation has something called PD Generation,
Mm-hmm.
PDGENE ration. It's free.
Mm-hmm.
If you have Parkinson's disease, you can go on their website. You can actually, they will mail you a kit. You take a free blood sample, and they're testing all these genes to
Mm-hmm.
see if you perhaps have a gene that contributes. And that's another difference. YOPD, typically there could be some gene involvement,
Mm, okay.
um, just because it's 4 to 10% of the Parkinson's population is actually YOPD. So
Mm,
you think it's not a not a lot of numbers, and then you
yeah.
take that. And then in the Michael J. Fox Foundation, they've got a smell test that you can go on there online that is free. They will give you samples, and you do not, I might I might be wrong, but I'm pretty sure you don't have to have Parkinson's to participate in that one.
Mm,
Another one that I've been participating in, and you do not have to have Parkinson's because they want data from everyone.
mm,
It's called PPMI. It's Parkinson's Progressive Matrix Index or something, where quarterly I fill out online survey,
mm,
and they're looking at the progression of my symptoms, both motor, non-motor, over time. I've been doing
okay.
that for about 3 years. So,
Mm-hmm.
um, yeah. So my mission is to really highlight that women are underrepresented in
Mm,
research. There's a
mm-hmm.
movement. Uh, many of us women are pounding on the doors that are, have PD and advocates,
Mm-hmm.
like we did in Capitol Hill March. I was invited to participate in the first Parkinson's Policy Forum,
Mm,
where about 350 people with Parkinson's and caregivers showed up on Capitol Hill. Not just showed up; it was a very well orchestrated 4-day event through
mm,
the Parkinson's Foundation, Michael J. Fox Foundation, PD, Alliance is another
Mm,
organization, and the American Parkinson's Disease Association.
mhm,
And we went and talked to our congressman,
mhm,
and asked for increased funding to the tune of $600 million for research. It sounds like a lot, but it's really not compared to
mhm,
Alzheimer's. They're getting a lot of research money.
mhm,
And we asked for the National Parkinson's Plan that was turned into law July 2nd of 2024. That has sat, not
mhm,
moved. So now it's finally moving. As actually today, you can go online from 10 to 4 today on. Well, I mean, this is live, so it's not going to happen. But but I'll tell you, NIH.gov/live, they are having their first live meeting of the council that was finally
mhm,
set for the National Parkinson's Plan. So we're finally getting some traction.
mhm,
Now that we've got it,
mhm,
the council said, now we can say how the money's going to go.
mhm.
Yeah, I know that
Wow.
was.
No, I mean, it's great. I love that you're involved, and I love that you're sharing how others can get involved, because it sounds like, big or small, and even people without Parkinson's. So there are opportunities to get involved. And I think it's helpful just to know what those can look like and how to access them. So I'll put in the show notes some of those websites that you mentioned so that people can easily get to them. So yeah,
That would
thanks
be
for,
great.
yeah, letting us know about that.
Yeah, there's room for everyone to advocate.
Mm-hmm. Oh,
Yeah.
that's great. Well, and then I know you mentioned the fireside chat. Was that what you were? That's different than what you were talking about.
So,
Yeah.
yes. So
Okay. I want to hear about
I,
that.
it was, so David and I were invited, Dave is my husband. I was invited to attend the Michael J. Fox Foundation first ever social media summit. It's a mouthful, for social influencers and advocates within the Parkinson's community. And there were not a lot of us. I want to say, I'm going to be wrong on this because I'm horrible in numbers, but maybe 15 from across the country. And it was a day at the foundation headquarters where we were brought together to learn how to collaborate, since we're using the social media platform, how to collaborate with one another, how to understand how the social media works in terms of getting a further reach with the analytics. And Rebecca King Cruz, who is the wife of Terry Crews, football player, a TV show he's on too. She's was recently went public with her diagnosis because she had focused ultrasound. So she talked to us about that experience. During that day, it was a day of learning, training, collaboration. And then we had a 30-minute opportunity
Mm-hmm.
where Michael J. Fox himself, the
Oh,
GOAT, greatest of all time,
yeah.
he came in, and we all kind of, we sat in our little chairs in front of him, and he told us about his journey when he was 29, and no one was doing what we are now doing as social media advocates,
Mm-hmm.
influencers in that community. And so he, first of all, I'm going to cry now.
Oh,
Sorry.
it's
I,
okay.
I literally sat there for probably the full 30 minutes trying not to ugly cry, because it was just, and one of the people from the Fox Foundation, came and held my hand. She's probably thinking, okay, get it together, girl. But, he was so gracious, and he thanked us for doing what we're doing. And it's so humbling. He thanked us for going on social media and being vulnerable
Mm-hmm.
and disclosing our diagnosis, which my mission also is to break the stigma of Parkinson's disease, of young onset, and of mental health, depression, anxiety,
Mm-hmm.
because there should be no shame around any of these diseases. We didn't ask for them. And
Mhm.
we, we need to, when my son said sharing stories builds community, that's the
Mhm.
whole thing. We want to break the stigma, build a community, because if we don't, we can't access help. So he thanked us for doing what we're doing. Um, he talked about, and this was very touching to me because it was the same exact thing with my parents. Um, his dad passed before he knew Michael had Parkinson's. So his dad didn't have to
Mm.
experience that, but his mom was alive. And he said, my mom worried about me for the rest of my life, as moms
Mm.
do. And that was exactly my situation. My
Mm.
dad passed away 3 years before my diagnosis. Thank God, because it would have killed him.
Mm.
His mom actually had Parkinson's disease. So my paternal grandmother,
Mm.
I know he probably would have created like, oh, it's my fault for,
Mm.
which he shouldn't, of course. But my mom, the very first thing she said to me when I told her was, Amy, no, you can't, because I won't be around when you need me.
Mm.
And so I found myself, trying to comfort my mother. And I reassured her. I said, Mom, you'll always be here with me. I've got David. And she passed the next year. Um, so I'm grateful she hasn't had to watch
Mm.
and feel and see, because no mom wants to experience that.
Mhm.
So he shared that. And he also talked about how, like, Muhammad Ali kind of passed the torch to him,
Mm.
and he's passing the torch to us to continue with our advocacy. And that's why I say it's not just us. We may be like the first kind of group to be very visible, but I invite anybody who wants,
Mhm.
there are more people than just us, and anybody can be an advocate. All you have to
Yeah.
do is say, I want to help. That makes you an advocate. So it was very cool from a speech pathology, standpoint. Of course, I was tuned into all the things, um, and I won't, go in and share that part, but I just to be in that space.
Yeah. Oh,
It's
yeah.
one of the highlights of my life,
Mhm.
other than becoming a mom. Yeah, those two experiences,
Yeah.
but and he is just what he's so authentic and genuine and kind and such a visionary,
Mhm.
cool dude. Like, I
Mhm.
mean, he's just, what you see is what you get.
Yeah.
No pretense. So we're,
Mhm.
the community is very lucky to have him, have
Mhm.
been kind of the lighthouse, as I say, as we follow. So
Yeah. Well, that sounds like a very powerful experience.
it
And
was, it
yeah,
was.
and I
I knew
love
I
that.
would make it through this without crying, because
No,
that's
well,
me.
I have to tell you that I've teared up about 4 times, but thankfully I don't have to talk as much so that I can get back to
You can
not the
kind
tearing, but
of,
but yeah, no, thank you for sharing that, and I love that idea and just that image of passing the torch and then I'm picturing all of you with your torches that are working towards that advocacy and yeah,
yeah,
like you're saying, the more torch, I guess the bigger the flame, right? The bigger the tide of change that you can make. So, yeah.
girl, I'm a, I'm gonna steal that from you.
Okay, you should. That's good.
I will quote I always give credit to my son about sharing stories. The more torches, the bigger the flame. Beth
Okay, there you
Peterson.
go. There you go. Okay. Well,
That's so
great.
good.
Well, I just had one more I feel like I could talk to you all day, but I've got one more question for you. And since we do have a lot of clinicians in the audience and healthcare providers, and as you've shared, you've seen it from both as a clinician and as a person with Parkinson's. What's the biggest lesson that you want healthcare providers and clinicians who are listening, what do you want them to take away from your story?
Yeah. I th- I'm gonna share one thing for other people with Parkinson's, especially people diagnosed with young onset
Mm-hmm.
Parkinson's disease. But I'll start with the clinicians first. This is a hard disease. This is a hard disease to have. Um, it's a hard disease physically. It is a hard disease cognitively, emotionally, and there's no cure. And there's nothing that slows the progression in terms of medication, treatment. I mean, we have deep brain stimulation
Mhm.
that I want every clinician to know is a thing, because I'm still shocked sometimes when I'm there, people are like, what? Deep brain? And
Mm.
that's okay. You don't know what you don't know. But
Yeah.
I want people to know about deep brain stimulation, because that can impact cognition and speech and voice. So that's probably one reason I
Mm.
will never get it. Now I
Mhm.
don't even know that I'm a candidate for it, because I already have the mild cognitive impairment, and
Mm.
DBS can expedite that. Not in everyone, but just know those kind of things. But just know that you are a valued person.
Mm.
As a speech pathologist, I'm going to cry again. Pull it together, Amy. I have I have gotten so many DMs, direct messages from care partners who have said, "Thank you so much for what you do."
Mm.
Like, as a speech pathologist, my husband, and I'm not their speech pathologist, they're just speaking generally. My
Mhm.
husband can out swallow safely, and we
Mm.
can hear him again.
Mm.
And just know how valued you are,
Mm.
even if that masked person with
Mm.
Parkinson's who has apathy is sitting in front of you, and you feel like you're thinking, oh God, this is going to be the hardest hour of my life. Just know if they're sitting in your chair,
Yeah.
that's a get, and just keep at it.
Mhm.
And then the other thing, well, and then also, you've seen one person with Parkinson's, you've seen one person. So even though
Mhm.
as a speech pathologist, if you look and say, oh, we shouldn't expect to see dysphagia till later,
Mm.
okay, generally. But if your person comes to you and says, I'm experiencing dysphagia, they are the experts of themselves.
Mhm.
And that's a big thing that we tell people. We might be experts as speech language pathologists, but that person sitting in front of you is the expert of them. So
Mhm.
really
Mhm.
listen to what they're saying.
Mhm.
And then for people that have young onset Parkinson's diagnosis, whether you're a speech pathologist like me and have it, or just, not, if you are diagnosed, when you decide to disclose that diagnosis is personal and your choice.
Mhm.
If you don't want to disclose it to your employer or your friends or extended family member, that's your choice.
Mhm.
If you do want to disclose it, that's your choice. Um, Now with the employer, I've done some ADA stuff, and that's a whole nother discussion. We don't have time for that, American Disabilities Act. But I do think that we are obligated, and I have always been, obviously I'm an open book, so I have always been forthright, but I did take 7 years of that diagnosis to not share with people, for fear of stigma, for fear of
Mm.
people looking at me. I didn't want to burden my colleagues, and just a whole level of things. But when I did disclose after 7 years, the biggest weight off my shoulder
Mm.
happened. And I wish I
Mm.
disclosed sooner. Yeah.
Mm.
And we do, from an ethical standpoint, certainly clinicians, if you are like me, you need to disclose. For example, the reason I disclosed was we started doing fees training, and I had to tell my manager. I was trained back in the day, like in 1995, when we did fees, but I hadn't done it, so I was going to get retrained. But that's when I told my supervisor and said, I've got something to tell you. I don't think I should be passing a scope.
Mm.
you know i've got
Mm.
i've got Parkinson's. And she's like, oh God, thanks for
Mhm.
telling me. I'm not going to try and scope someone, and I'm sitting here doing this. It's kind of funny, actually,
Yeah.
when I think
Yeah.
about it myself, but it's not. So but yeah, it's up to you when you want to
Mm.
disclose. And that's
Mhm.
often the hardest thing for people when they're young, because we still have to work, we've got to pay for
Mhm.
kids, we've got incomes, jobs, we're tired.
Mhm.
Yeah.
Yeah. No, that's good. That's good. I feel like you've provided a lot of good wisdom and advice to know, yeah, what it is your choice. I think that's really a good message to take away.
Yeah. Yeah.
Yeah. Well, I do want to make sure I give you the last word. Was there anything else that you wanted to share before I wrap up?
Yeah. Well, I think I just did, Beth. I think
Okay.
that would have been
Good.
my it's a very personal decision,
Yeah.
just know that, you can live a fulfilled, long life with
Hmm.
Parkinson's
Hmm.
and access your resources.
Okay. I
Yeah.
love it. That's a perfect takeaway. Well, thank
Perfect.
you. Well, thank you so much for joining us today. I really appreciate your time. And I'm just going to kind of wrap up and make sure that I'm giving credit where it's due in this last part of our episode here. So
Good.
I want to again thank our guests. So, Amy Chrest, thank you so much for joining us. We really appreciate all that you've shared with us today. And
Pleasure.
then,
Thank you.
yeah, I'll put I know you shared some of your social media handles with me, so I'll put
Mhm.
those in the show notes. So you have Instagram, so Amy Strong AF, and then
Mhm.
Facebook as Amy Hutchins Crest. And again, I'll put
Mhm.
the link so it's easy to find those. And I'll also share the links to the Parkinson's Foundation and the Michael J. Fox Foundation that you shared, particularly the research link so that people know how they can get involved. So thanks for sharing those.
Yeah, absolutely.
And yeah, and I just want to also credit our theme song. So, our listeners at the beginning and end of the episode hear a theme song, and it's called Think Loud for Parkinson's by Kindred Spirit and Leo Sayer. And that was a song and video designed and inspired by LSVT Loud speech treatment. And it was developed to raise awareness for Parkinson's worldwide. And that's available for download and streaming on all major music platforms. And proceeds benefit the UK charity Cure Parkinson. So I'll put a link to that video as well for those interested. I want to thank our production team, CS Design Studios. So they help do all the behind the scenes work to make the podcast possible. And if anyone's interested in learning more about LSVT Loud speech therapy or LSVT Big physical or occupational therapy, or if you want to locate therapists in your area, you can visit our website at lsvtglobal.com. And then I encourage you to click subscribe wherever you get your podcasts so that you never miss an episode. And we look forward to thinking big and loud with you again next time. So thanks for joining us.
Yeah, yeah, yeah. I speak up, 'cause I wanna be